might introduce Paul as our next speaker. And Paul was very generous with his time today because he only found out this morning that he was going to be speaking as a replacement for Professor Shellac, who obviously I've said could not make it under the circumstances of the family emergency. And so it was very, very nice of Paul to come along and say, yes, I'll present. And so his topic is going to be looking at mainly a study that he's been involved in throughout his PhD, with a focus on therapeutic drug monitoring. And he's looking at an international perspective on access, utilization barriers, and clinical value. A little bit about Paul. He's based at the Sunshine Coast University Hospital. And as he's also part of our group, a very important member of the Antimicrobial Optimization Group. He's a postdoctoral fellow at UQ and assistant director of pharmacy up at the Sunshine Coast Hospital. He also works as an ICU pharmacist there, and his research focuses are on optimizing antimicrobial dosing in critically ill patients through improved antibiotic strategies, including dosing guidelines, TDM, and precision dosing. So I'd like to introduce Paul. And with Paul's talk, because he's a fill-in and he has to head off, we might take some questions straight after his presentation in case anybody has some really burning questions for him. So thank you, Paul.
So yeah, I'll be presenting a survey recently conducted. So antimicrobial therapeutic drug monitoring in critically ill adult patients, an international perspective on access, utilization, barriers, and clinical value. I'll be presenting on behalf of the authorship group there, and also on behalf of the European Society of Intensive Care Medicine and the study group of infections in critically ill patients as part of ESCMID. So I'll probably just skip over some of the background. As we all know, critically ill patients with serious infections, they've demonstrated altered pharmacokinetics, which is shown on the right here. Of altering either your volume of distribution or your clearance, which will lead to either subtherapeutic or potential toxic exposures. We know that traditional antimicrobial dosing strategies risk inadequate therapeutic response. So therapeutic drug monitoring, it's an individualized approach. It improves therapeutic drug concentrations, minimizes toxic exposure, now recommended in some consensus guidelines for specific indications. And then in terms of improved patient outcomes, which has previously been discussed, it's still unknown or to be quantified what the benefit is, especially in critical. So the aim was to survey a large cross-section of clinicians working in ICUs worldwide to describe their perspectives of access, utilization, barriers, and clinical value of antimicrobial TDM in the treatment of adult patients with serious infection. So this was an online cross-sectional survey using REDCap. It was developed by the authorship group of international experts. The results I'm presenting today are derived from multiple choice questions and 5-point Likert scale. And they describe, one will be the access to MIC results, drug assay availability, TDM utilization, and clinical value of specific dose optimization strategies. This survey was distributed by professional societies around the world and through networks. And these are some of the results. So we had 538 respondents from 409 hospitals, 292 cities in 45 countries. So around half of the respondents were from high-income countries, 23% from upper middle income countries, and 23% from either low middle income countries or low income countries. 30% of respondents were from Europe and Central Asia, which had the highest frequency of respondents. And then 71% were physicians and 29% pharmacists. And the majority of these were ICU specialists. Just added here as well, a breakdown of where the respondents were from. Maybe just to note, seeing Europe and Central Asia had the highest respondents. We had 78 respondents from Germany. And we move into Latin America, 21 from Brazil, low middle income countries, representation in Egypt, India, upper middle with Libya having 42. But so you can see there's a range of respondents throughout the world. So onto some of the results. So firstly is the MIC access. So this is important, obviously. So talking about precision dosing and knowing the pathogen which you're treating and being the denominator for PK/PD targets is an important consideration. So we found that around, about 60% had access to MIC results. And then that gets broken down further if it's to all susceptibilities or if it's only when requested by ICU and or ID. But probably more importantly, or of concern, was that 41% of respondents did not have access to MIC reports. The majority of those did have access to susceptibility reports, so they knew which pathogen they were treating. But this is probably more worrying, is that around a quarter of respondents from low middle income countries or low income countries had no MIC or susceptibility reports, so therefore being blind in what they are actually treating. As I've said, MICs are important. They're critical for ensuring appropriate antibiotic use and to prevent antimicrobial resistance. So this result shows the disparity in MIC access on a global level, and that broader access must be a priority. Then we move on to TDM availability. And I've just put here this paper from 2020, I believe, which was Abdulaziz et al., looking at or expert panel recommendations on antimicrobial therapeutic drug monitoring in critically ill adult patients. And essentially what I've shown here, they've recommended TDM by the panel for specific agents, which I'll go into in the next page. So what we want to look at of those agents, how many sites or respondents have access to TDM. So the agents included vancomycin, aminoglycosides, voriconazole, beta-lactams, linezolid, ticaplanin. So in A here in this figure, this is showing in green if people have access to that drug assay, and then B here is it available as required, being in green. So therefore, the results can be interpreted clinically before the next dose is due. So in A, you can see that vancomycin and aminoglycosides were the only assays that were readily available to the majority of respondents. And you can see here with the green going down that these agents became less and less available, the assays availability. And then likewise, vancomycin and aminoglycosides were the only agents where the assays were available and your assay results were available in a timely manner that could be used clinically. Where we can see with the others, we start to get these different shades of green where the assays are batched either twice weekly or weekly. So if we're just to focus on vancomycin and aminoglycosides, we found that high-income countries had the greatest access, which is to be expected. And with these agents, TDM approach is well established. So it was interesting or concerning that around a quarter of respondents did not have access to vancomycin or aminoglycoside assays. That's across the board. And then when looking at low middle income countries or low income countries, around greater than 38% did not have access to vancomycin assays, and over half did not have aminoglycoside assay access. So this shows us that evidence and guidelines supporting TDM are slow to translate into clinical practice, and that equitable access remains a challenge. So we'll move on to TDM barriers, and respondents were asked in your ICU, rate the following in terms of being a barrier to performing TDM or dosing software. The red being extreme barriers, green being not a barrier. So the two most significant barriers were delayed drug assay turnaround time and assays not being available. And this is consistent with the literature over the last 10 years. They have been consistently two biggest barriers. I have just highlighted here in red, so we're talking about dosing software, that these are also barriers identified. with insufficient expertise to use dosing software considered a pretty significant barrier. And I know from my personal experience and from some previous literature that there's large variability that exists in antimicrobial precision dosing program characteristics. So it's foreseeable that there would be that insufficient expertise would be considered a barrier, even within the same program. It may change, week to week, month to month, and learning that the changes that have occurred is tricky. We found across the board with TDM barriers that, as you would expect in high-income countries, these barriers were considered less significant. And previous studies have shown that precision dosing, accessibility, training, and clinical expertise have been identified as key requirements moving forward. So just moving on to ordering and responsibilities of TDM and dosing software. So this is just essentially who's ordering TDM, who's adjusting their doses. So in ICUs, what we've found that with ordering TDM, that it's largely the role of an ICU physician. Here, just noting that respondents could select multiple options. So it'd be a combination of a physician and a pharmacist, but generally it was the ICU physician's role. And then once TDM was performed, it was still largely the ICU physician's role to then adjust dosing following TDM. If we then move to dosing software, this is where it changed a bit. So ICU pharmacists 49% of the time, AMS pharmacists 42% of the time. So between the two, it was more of a pharmacist-led role to utilize dosing software programs, but the ICU physician also being involved there. Other things of note that we found that in North America, in terms of ordering TDM and adjusting dosing for TDM, this was largely the role of a pharmacist in over 90% of respondents. And we found that dosing software use was by 12% of respondents. They generally use dosing software, and it was more common to be used in high-income countries and in East Asia and Pacific regions. I did just put this up here as well. I'll just leave it for a second, just to show the breakdown of dosing software use, but also which programs are used in which area, broken down in total by region or by incomes of the country. There was no real one program that was used specifically, but more that certain programs were preferenced in certain regions. So ID/ODS being in East Asia and Pacific, CADI being European, generally being where the potential either where the software is made, but it seems to be pockets in different areas, but no consistency in which program is used. And then just move on to improve patient outcomes. So essentially just asking the following antibiotic dosing strategies improve patient outcomes when treating critical ill patients with infection. We do know that the evidence to support this for TDM is, it's not definitive evidence by any means at this point. But when we did look at these options, so TDM dosing guidelines, dosing recommendations during ID rounds, and the use of dosing software, TDM was found by respondents they were in the most agreement that TDM improved patient outcomes. This was most common belief in high-income countries. Again, TDM's more readily available there. Potentially, clinicians are more familiar with the TDM principles and literature, or maybe they have first-hand experience where they've seen the benefits. Of all the options there, dosing software was still a quarter of respondents were, neither agree or disagree if it improves patient outcomes. And the other one of interest there being that, TDM versus dosing recommendations from ID rounds, that there'd be greater agreement that TDM would improve patient outcomes there. Also, this, of course, could lead into a limitation of this study with respondents potentially being pro TDM. So I'm going to wrap it up there. So the main conclusions from what I've presented today, I guess one being the geographical disparity in clinician access to timely drug assay results. and MIC and susceptibility results. And it probably potentially plays into what Ken has just nicely presented on novel agents for TDM, and potentially down the path, if they were cost-effective point of care, then maybe they could be introduced into areas that don't have the capacity or feasibility to perform drug assays. We found that dosing software was rarely used in clinical practice, but it's predominantly the role of the pharmacist in ICU. And we found that respondents believe that TDM improves patient outcomes, although there are significant TDM barriers that have been identified and still remain in practice. So just like to acknowledge the societies that distributed these surveys listed there. Also the non-author contributions for also distributing the survey to through their local channels. And just like to recognise some funding there that helped support this study. So I will wrap it up there, Oz, and happy to take any questions. Thank you.
Thanks, Paul. That was excellent, and I know that you might be a little bit time for with getting a lot of questions, but I might just put some. I'm just looking through and seeing. We've got some questions for the second speaker, so I might just put one for you with regards to the data that you presented regarding MIC availability. Now, it's quite clear that there was a lack of MIC availability among, I think, the lower middle and lower income countries, large chunk of them. Keeping in mind, in the context of therapeutic drug monitoring and dose optimization, what advice would you give? So it's two parts of this question. What advice would you give to those centers that don't have this MIC data readily available? And of course, even if you do have the MIC data available, what caveats would you put in to interpreting them with respect to dose optimization?
Yeah, thanks for the question. So it's tricky when you don't have it, but I guess there's a few parts to that question. So I guess one is, even if you do have MICs available, there's still it's up for debate of if you should use that value or use the cutoff value, depending where the MIC sits. So potentially, I think having susceptibility and knowing what the pathogen is would be a great start. When you don't have that at all and you're blind, then that makes it very difficult. But if you have that, I think that's a reasonable start, and probably a good approach for when you are using precision dosing or using a denominator to account for those variability in MIC determinations. So I think that's a reasonable approach. And then if your MIC is not available and you have no susceptibility, then I mean, that's a bigger, broader question of societies and governments, and to actually step in or to promote that availability.
Very good response, Paul. I know that these are the type of questions that you get fired at when you're doing your PhD, and you can speak at length of them. So I thought I'd just be a bit of a devil's advocate and ask them.
Thanks,
but thank you very much. I'm just looking to the floor here if anybody's got any other follow-up questions for Paul. Otherwise, I might move on. I'll just see if there's nothing here. There's one more, Paul, just from Daniel online. Did these countries have antibiograms?
So I guess that's the same thing to susceptibility. So that was where a quarter of the low income countries and middle income countries did not have antibiograms available, according to the respondents.
Right. Well, look, we're very grateful that you could present at such short notice, Paul, and we understand if you have to head off, then by all means, please do. And yeah, very grateful. Thank you. Thanks very much.
Okay, thanks, Oz. Thanks for the opportunity. Thank you.